Hi friends, welcome to PharmaGrid. So in this session we will continue with the patient case-based clinical oriented type of questions. So starting with the first question. A 66-year-old man has been admitted in the surgical ward for 14 days and it is suspected to have MRSA infection, that is methicillin resistant Staphylococcus aureus infection in his wound. He started on vancomycin 1500 mg IV as a loading dose followed by 1000 mg every 12 hours. He has normal renal function and his weight is 70 kg. What is the recommended time to take vancomycin serum levels, which means the trough level? So here the options are 1 hour after the first dose, after the second dose, 30 minutes before the fourth dose, after the fourth dose. So here the correct answer is option C, which is the recommended time to take the trough level of vancomycin. As the prescribed drug is used or metabolized by the body, the drug level decreases. The lowest level of the drug in the patient's body is called the trough level, whereas the peak for a drug is when the level of the drug in the patient's body is the highest. So trough level is the lowest level of drug in the body, whereas peak level is the highest level or the highest concentration of drug in the patient's body. Blood should be drawn immediately before the next dose to assess drug concentrations during the trough phase. Whereas to assess the peak levels, the time for drawing depends upon the route of administration. For example, in case of intravenous route, 15 to 30 minutes after injection or infusion. In case of intramuscular route, 30 minutes to 1 hour after injection, whereas oral route, 1 hour after the drug is taken. The trough serum vancomycin concentrations are the most accurate and practical method for monitoring efficacy and safety. For example, one of the important toxicity of vancomycin is nephrotoxicity. For patients with normal renal function, it takes approximately 4 doses of vancomycin to reach the steady state. So trough concentration should be drawn 30 minutes before the fourth dose. Trough concentrations may be drawn earlier in critically ill patients than patients with unstable renal function and patients on vancomycin dosing interval more than or equal to 24 hours. It can be measured before third dose in patients which renal impairment and risk of toxicity may be greater. So in this slide you can see vancomycin initial dosage regimens for patients with impaired renal function. So in this column you can see the estimated glomerular filtration rate, and here actual body weight of the patient is given. That is less than 60 kg, 60 to 80 kg, 81 to 100 kg and greater than 100 kg. And in this column they have mentioned the timing of trough levels. Trough level means the lowest level of drug in the patient's body. So let's take an example. If the patient's EGFR or estimated glomerular filtration rate is greater than 90, okay, and the patient's weight is less than 60 kg, then the dose of vancomycin is 750 milligram Q8 hourly. Okay, Q8 hourly means every 8 hours. And if the patient's body weight is in between 60 to 80, the dose will be 1000 milligram Q8 hourly. And if the weight is in between 81 to 100 kilogram, the dose will be 1250 milligram Q8 hourly. And if the patient's weight is greater than 100 kilogram, 1500 milligram Q8 hourly. And the timing of trough will be 30 minutes before the fourth dose. Okay, so likewise you can see whatever the glomerular filtration rate, that is estimated glomerular filtration rate, and you can check the patient weight and take the dose or choose the dose appropriately, and the timing of trough levels you can see in this image or in this tabular column. So the next question, patient with creatinine clearance of 15 ml per minute is diagnosed with DVT, that is deep vein thrombosis. What is the recommended dose for enoxaparin? Patient weight is 60 kg. The options are 60 mg once daily, 60 mg twice daily, that is BID, then 45 mg BID, 45 mg once daily. So here the correct answer is option A. Why? Because given that the elimination half-life of low molecular weight heparin, this enoxaparin is a low molecular weight heparin, that is the elimination half-life of low molecular weight heparins is prolonged in patients with severe renal impairment. High doses may lead to a significant accumulation in these patients. So the enoxaparin dose should be reduced and the dosing interval extended to once daily in patients with creatinine clearance less than 30 ml per minute. Okay, so here the patient's creatinine clearance is 15 ml per minute, that is which is less than 30 ml per minute. Hence the answer came as option A, that is 60 mg once daily. So in this slide, you can see the enoxaparin dosing recommendations. Okay, so what all are the indications and the creatinine clearance, the dosing based on the creatinine clearance. If it is greater than or equal to 30 ml per minute, then less than 30 ml per minute. So let's say the first indication, inpatient treatment of acute deep vein thrombosis with or without pulmonary embolism. If the creatinine clearance is greater than or equal to 30 ml per minute, the dose of enoxaparin is 1 milligram per kilogram subcutaneously every 12 hours or 1.5 milligram per kilogram subcutaneously once daily. And if the creatinine clearance is less than 30 ml per minute, 1 milligram per kilogram subcutaneously once daily. And next indication is outpatient treatment of acute DVT without pulmonary embolism. And if the creatinine clearance is greater than or equal to 30 ml per minute, dose is 1 milligram per kilogram subcutaneously every 12 hours. And if the creatinine clearance is less than 30 ml per minute, the dosing is 1 milligram per kilogram subcutaneously once daily. Okay, so also in case of prophylaxis of ischemic complications of unstable angina and non-ST segment elevation of myocardial infarction, the dosing is same. Okay, so if the creatinine clearance is greater than or equal to 30 ml per minute, usually enoxaparin is given as 1 milligram per kilogram subcutaneously every 12 hours, and if the creatinine clearance is less than 30 ml per minute, 1 milligram per kilogram subcutaneously once daily. So let's take the case of this patient. Okay, here the patient weight is 60 kilogram. Okay, so and the patient has got severe renal impairment. Creatinine clearance is 15 ml per minute. Okay, so it comes under this category. So what will be the dosing in this patient? 60 milligram. Okay, so patient's weight is 60 kg. So 60 into 1 is equal to 60 milligram given subcutaneously once daily. Okay, so hence the came answer as option A, that is 60 milligram once daily. Next one, a 28-year-old woman presents with tachycardia and palpitations, that is ventricular ectopic beats. History revealed essential hypertension and asthma. Patient wants to conceive, that means to become pregnant. Blood pressure is 147/98 mmHg. What is the most likely alternative to the beta blocker in terms of efficacy on pressure, heart rate and relative safety? So the options are prazosin, enalapril, diltiazem, methyl dopa. So here the correct answer is option D, that is methyl dopa. Methyl dopa is often considered the first-line therapy for pre-pregnancy antihypertensive treatment with the largest quantity of data regarding fetal safety, since it has been used for pregnancy hypertension since 1960s, even in the first trimester. In a 7.5-year follow-up study, there were no adverse growth or developmental outcomes in children whose mothers received methyl dopa during pregnancy. Many clinicians opt to change women's antihypertensive therapy to methyl dopa prior to conception, especially if they require more than one drug, and it is unlikely that they will be able to discontinue therapy in early pregnancy. Lebetilol, a combined alpha blocker and beta blocker, is an alternative to methyl dopa as it is well tolerated with an easier twice-a-day dosing schedule than methyl dopa, particularly for severe hypertension. The majority of the guidelines recommend that women on angiotensin converting enzyme inhibitors or angiotensin 2 receptor blockers and planning to become pregnant have to discuss with their doctor prescription of an alternative. Antihypertensive treatment should be discontinued in women taking AC inhibitors or ARBs if they become pregnant, preferably within 2 working days of notification of pregnancy, as AC inhibitors and ARBs are teratogenic, with increased risk of congenital abnormalities if taken during early pregnancy, and they are therefore contraindicated. Diltiazem is only recommended for use during pregnancy when there are no alternatives and the benefit outweighs the risk. Moving on to the next one. A 42-year-old patient with asthma has received pneumococcal vaccine 4 years ago and asks if he needs to take it again. What is the suitable action? The options are: patient does not need another dose until he is 65 years old, administer PPV 23, administer PCV 13, another dose is not needed. Here the correct answer is option A. Patient does not need another dose until he is 65 years old. There are mainly two different types of pneumococcal vaccine, that is pneumococcal conjugate vaccine, which is denoted as PCV. This is given to all children under 2 years old as part of the NHS childhood vaccination program. It's known by the brand name Prevenar 13. And the next one is pneumococcal polysaccharide vaccine, that is PPV. This is given to people aged 65 and over and to people at high risk due to long-term health conditions. Babies receive the pneumococcal vaccine as separate injections at 2 months and 12 to 13 months. People over 65 only need a single pneumococcal vaccination which will protect for life. It is not given annually like the flu jab. People with a long-term health condition may need just a single one-off pneumococcal vaccination or 5-yearly vaccination depending on their underlying health problem. The overall benefits of vaccination against pneumococcus remains controversial. Despite this, both ACIP and CDC recommend vaccination for all adults with asthma, COPD and cigarette smokers. It is recommended for all adults over the age of 65 and any patient 2 years or older at high risk for invasive disease including smokers and patients with chronic lung disease. Revaccination is recommended for patients at high risk of invasive disease and should be given no sooner than 5 years from the previous vaccination owing to potential increased risk of adverse effects if given sooner. Patients 65 or older should only be revaccinated if the previous dose occurred when they were less than 65. Contraindications include a previous history of anaphylaxis to vaccine components and pregnancy, although women at risk of invasive pneumococcal disease should be vaccinated prior to pregnancy. Question number 40. A 22-year-old woman presents to the student health clinic inquiring about a progesterone-only birth control pill. She is concerned that taking an estrogen preparation will cause her to have bloating and swelling. The rationale against the use of progesterone by itself as a birth control agent is because of the options are bad taste in the mouth, cost, dosing bi-weekly, low bioavailability, slow metabolism. Here the correct answer is option D, that is low bioavailability. Progesterone by itself is not widely used as a contraceptive therapy because of its rapid metabolism, which will result in low bioavailability. Synthetic progestogens used in contraception are more stable to first-pass metabolism, allowing lower doses when administered orally. Now let's see why the remaining options are wrong. Option A, this pill is swallowed whole but can have a bad taste if bitten. Then option B, cost is not the reason why this agent is an ineffective birth control method. Then option C, the dosing for this agent would be daily. Then option E, metabolism of progesterone is rapid, which results to low availability. So low bioavailability is the reason behind why progesterone is not effective or progesterone is ineffective as a birth control pill agent by itself. Okay. So with this question, we have completed today's question discussion. Thank you everyone. Please like, share and support. Have a great day.